Yeah, I'm doing the webinar right now. That subject.
Hey, Professor, we
Yes.
lost audio. I don't know if you can hear me, but the audio is not coming
There
through for me.
is no audio yet. The
Okay.
webinar begins in 3 minutes. Yep. Thank you, though. All right. Good morning, good afternoon, whatever time it happens to be where you are. Sorry for the technical difficulties. When I loaded the PowerPoint, it was playing the recording from the pre-webinar, so that's what you guys were hearing. But wanted to make sure we were starting at the right time. So, again, I'm Dr. Derp. I'll be facilitating the webinar today and presenting, and then we have Professor Jackson in the chat. So, questions can be directed there, but I encourage you to keep any kind of non-content, non-slide related questions and comments to the end when we'll have plenty of time to answer that. And that just helps us to kind of keep on track for everybody. Just friendly reminder to keep yourself muted unless you are answering a question, answering or asking a question, your hand has been raised. And then also, just being mindful if you are on camera. We love for you guys to come on camera, but if you are being mindful that you are being recorded. All right. All right, we will go ahead and get started. So this is our first week of cognition in week 8, and we'll jump right in. So we're going to start with an engagement prompt. The nurse is planning activities for a client diagnosed with bipolar disorder with aggressive social behavior. Which activity would be most appropriate for this client? A, chess, B, writing, C, ping pong, or D, basketball? All right, seeing lots of B's in the chat. Fantastic. All right. Does anybody want to give me their rationale for a B answer before I jump over? Michelle.
Well, I don't know if this is right. This was my reasoning.
Okay.
Ping pong, chess, and basketball are all sports, so they instill a kind of, attitude where you want to win. So that might aggravate somebody who's already aggressive, and writing is an individual thing. So there's less risk there.
Okay. Awesome. Amanda. And then we'll go to the answer.
Okay, so I also chose writing, but I work in an acute psych setting, and I will say that my first thought for each one of them is that they all have the potential for dangerous behavior. I do think that chess you could throw pieces at someone, ping pong, you can aggressively hit the little ball. Same thing with basketball. But with writing, I also think if you're not in a controlled environment, a writing utensil can be used as a weapon. So I'm hoping that they have like patient pens that are flexible and not able to hurt. But I do think it's the most calm activity for someone with aggressive behavior. So that's why I chose B.
Okay, awesome. Thank you. Yeah, so we agree, right? So writing is going to be the most appropriate because it's a solitary activity that requires a short attention span with a mild physical exertion, and is the most appropriate activity for somebody who is exhibiting aggressive behavior. So writing or journaling, walks with staff, finger painting, or activities that minimize stimuli and provide a constructive release for tension. So the remaining options have a competitive element. So that's that kind of like sport, right? To them that should be avoided because it can stimulate aggression and increase psychomotor activity. So definitely Michelle. And then, yeah, Amanda, I agree with you. Giving people things that they can use as weapons probably isn't ideal. Maybe he's writing with a crayon, right? So, um, things that are going to be less concerning for risk for injury for sure. Good point. All right. So we have a scenario. Jamie is a 29-year-old woman who is in the emergency department with acute psychosis. Jamie's mother brought her to the hospital because Jamie has been delusional and hallucinating. Her boss threatened to fire her for inappropriate behavior and not focusing on her work duties. Her mother reports that Jamie has refused to take her medications for the past week and a half. Jamie's 72-hour psychiatric hold will expire soon, and she will be staying with her mother upon discharge. Her mother is worried about her daughter, and she states Jamie believes that there is nothing wrong with her and that she doesn't need medication. Please make sure you're muted. Thank you. She believes that there's nothing wrong with her and that she doesn't need medication. What if we get home and Jamie decides that she won't take her medication? What am I going to do? So, what are some priority concerns that should be addressed prior to discharge? Any thoughts there? Amanda.
Medication non-adherence and the delusion and hallucinations.
Yeah, definitely. So those are definitely the basis for the safety concerns, right? Or priority concerns. And then from that, we want to make sure that both Jamie and her mother are safe, right? Ronise.
Physical harm, we want to make sure that mom will be safe. So we could probably implement um, a home care visit every now and then, a well visit or something just to check up to make sure that everyone is safe and sound. And of course, I also agree with the medication adherence
Okay,
and a
great.
little bit of education to both too.
Yes, definitely. Yeah, thank you. Jennifer.
Oh, hi. I think I think the nurse need to create a comprehensive discharge and safety plan prior to
Mhm.
discharge, such as crisis management. If any psychiatric crisis happen, like what should they do, or outpatient follow up after discharge, or who is going to support her? Maybe her mom will support her when she is home, or any safety plan that they can address. And the discharge plan will be good.
Yeah, definitely. Good. Thank you. All right. Um, sorry, I've got pop-ups coming into my screen and I can't see. Amanda, did you have something else you wanted to add?
Yeah, I think that in a situation where someone is on a 72-hour hold and they're not compliant with medications and they're still experiencing delusion and hallucinations, and they should be considered for an extension of their hold, because I don't think that she can safely be discharged if there's still a risk for herself to be a danger to herself or others.
Yeah, definitely. I think that's something to consider as well. All right, we'll take one more. Is it Odahen?
Oh yes, Otahe. I think
Okay.
you can also.
Oh, I think you're muted.
Oh, okay. I said you can also involve her in the discharge plan. So educate her
Mm-hmm.
the importance of taking her medication, find out the reason why she might not be willing or wanting to take the medication, and see if there is a way to, meet her halfway to encourage her
Yeah.
to take the medication.
Yeah, definitely. Thank you. All right, and Nasha, last one, and then we'll move on.
To educate the patient and the mom, and maybe a possible finding a support group. And I agree with the extension of the time. And of course, that seems like patient needs more education and understanding her condition.
Yeah, definitely. So, some education, some kind of gaining of that trust, and discussion of the importance of remaining on medication, and medication adherence. Definitely having a safety plan, right? Looking at some of the outpatient resources, so like support groups and that sort of thing, some community resources. Yeah, definitely. And then, so a SMART goal might be, we have a risk for injury, right? And so a specific SMART goal might be that by discharge, the client will be able to identify 3 benefits for taking medications and will comply with taking meds as prescribed daily. And like Amanda said, this might require a little bit more time inpatient before we're getting an effective discharge. So perfect. Thank you. All right. So another, actually, interesting. Okay. Looks like we have a question or an answer without a question. So, a safety plan might be that when she begins to hallucinate, she'll call her therapist and talk about what she should do, right? So, kind of understanding the risk for impulsive and aggressive behavior, and that it may increase if a client is receiving command hallucinations to harm herself or others. If the client is experiencing a hallucination, the nurse should ask the client whether he or she intends to hurt him or herself or others. And then talking about auditory hallucinations can interfere with subvocal muscular activity associated with the hallucination. So, like I said, I'm not sure where the slide went with the question on it, but just some things to consider with regard to hallucinations and a safety plan involved in that. All right. So, an NCLEX practice question. A client says to the nurse, the federal guards are sent to kill me. Which is the best response by the nurse to the client's concern? 1, I don't believe this is true. 2, the guards are not out to kill you. 3, do you feel afraid that people are trying to hurt you? And 4, what makes you think the guards were sent to hurt you? All right, lots of 3s, 1 or 2 4s in there. All right, who wants to share their rationale? Amanda.
I picked 3. I didn't pick 1 because it's not appropriate to minimize someone's belief system. Same with answer 2. And I didn't pick 4 because sometimes people have thoughts like that and don't necessarily know where they come from and aren't able to tell you why they feel the way they feel. They just do. And so I think it's important to ask them about if they're afraid and just inquire further about how they're feeling emotionally and mentally.
Okay, great. Thank you. Jennifer.
I also pick number
Oh, sorry,
3.
there were 2 Jennifers. I didn't even realize it. Jennifer
Oh,
Carrillo.
Okay. I was torn between 3 and 4, but I ultimately picked 3 because I feel like do you feel more concentrates on their emotions in the moment and it can help with de-escalation versus 4, I feel like can eventually have them kind of spiral more because they can start thinking about how the guards are going to hurt them.
Okay.
But yeah, I picked 3.
Okay. Thank you. Crystal.
I picked 4 just because I thought it was an open-ended question for them to kind of maybe make them think about what it is, and we're not I felt like using "do you feel afraid" maybe it was leading or something. That was just my thought.
Okay. All right. We'll take Jennifer Kuo and then we'll find out what the answer is.
Okay, I picked number 3. I think that is to acknowledge their feeling, and maybe I will also use therapeutic communication after that. I did not pick number 4 because even though it starts with what, but it still it makes me feel like it's a why question. Why, it's kind of
Okay.
we never want to ask why. And number 1 is I don't think it's true because it's kind of it will maybe the patient will argue with us, and that's not good. And the second one is definitely not good.
Okay. Yeah. So diminishing what they think is probably not the best answer. So people seem to be sort of torn between 3 and 4, and I'll admit I'm there with you. So the correct answer is 3. And the rationale is that it is the most therapeutic for the nurse to empathize with the client's experience. The remaining options lack this connection with the client. So disagreeing with delusions may make the client more defensive, and the client may cling to delusions even more. And then with regard to 4, encouraging discussion regarding the delusion is inappropriate. So it's kind of that why question of, probably we don't need to dig any deeper into it, but rather just empathize with what they're feeling in that moment. So, good answers. But I'm with you. I had to go back and forth between 3 and 4 as well. All right. A question from the pre-recorded webinar. What are the differences between dementia and delirium? Paula.
Dementia is progressive, a slowly progression. Delirium can appear fast or onset.
Okay, yeah. So definitely a different onset. So dementia is more gradual or insidious in onset, whereas delirium is more of an acute onset. Perfect. Yeah. What else? So I'm seeing in the chat that dementia is not curable, right? So Sandra, did you want to expand on that?
I don't know if I can necessarily expand on that specifically,
Okay.
but I was just yesterday looking into dementia for an assignment, and I know that it's like from what I learned yesterday is it's a neurodegenerative disease, as where I feel like delirium could be a symptom of dementia.
It can
rather than be, or I guess it could be a diagnosis, but yeah, that's where my headset is.
So it is a diagnosis on its own. Frankie.
Hi. So would you say delirium could be caused by a certain infection, like let's say a change of cognition, like a UTI, um, or maybe they had, let's say, sepsis and they started becoming high temperature, delusional, but is like pretty much, would you say it's due to like a change of condition, like an infection set in?
Yeah, definitely. So I think that's an important point is delirium is usually caused by some sort of other so I think this is what you were getting at, Sandra, is it's not necessarily a symptom of dementia, but it can be a symptom of other things like infection, any kind of brain inflammation is really the key there. So it's confusion caused by some other physical ailment. Yeah, Anasha.
I was going to say that delirium is more of a secondary to another probably condition or a side effect, and then dementia is a little bit of a more of a chronic that happens over time as we age, or maybe sometimes due to lifestyle or medications or trauma that people experience.
Yeah, yeah. So, yeah, definitely getting back to that onset where dementia is ongoing and progressive, right? And is a neurodegenerative disease, whereas delirium is, potentially a result of something else going on, a secondary condition. All right, last one, Jara.
I was gonna say, Professor, that dementia is irreversible, and then delirium is reversible with accurate and appropriate interventions.
Yeah, so I agree with that. I would say that it's not always 100% reversible, but it is treatable. So the more times we have brain inflammation, so say from UTI or from other infection, other sources, such as, it could be TBI, it could be a lot of different things. We might not get a full return to baseline, so that's something to consider as well. But we will, with appropriate treatment, get improvement, whereas we might not see that or we definitely won't see that in dementia in most cases. Good. Awesome. I think we covered it. Thank you. All right. Another NCLEX practice question. When planning the discharge of a client with chronic anxiety, which is the most important maintenance goal? Suppressing feelings of anxiety. 2, identifying anxiety producing situations. 3, continuing contact with a crisis counselor. Or 4, eliminating all anxiety from daily situations. Right, seeing lots of 2s in the chat. Fantastic. All right. So we'll go ahead and jump over to the rationale. So the answer is definitely 2, right? So recognizing situations that produce anxiety allows the client to prepare to cope with anxiety or avoid a specific stimulus. So counselors will not always be available for all anxiety-producing situations, and this option does not encourage the development of internal strengths. Suppressing feelings will not resolve anxiety, right? And 100% we are not able to eliminate all anxiety from life, right? So if only, but I think we might actually be sort of bored if we did that. All right. Kind of like with our stress and coping, we talked about good stress and not so good stress, right? So, stress has its place and it has adaptive properties, including in anxiety kind of goes along with that, right? But yeah, so definitely 2. And then just kind of looking at test taking strategy, I think most of you have identified this, but when it says most appropriate, right, we're looking at kind of eliminating options that contain closed-ended word all or suggest that feelings should be suppressed. Okay, so looking when we're talking about NCLEX questions, looking at kind of those key words and strategic words, like most appropriate, first, right? Those sorts of things. So good job. All right, we have a medication calculation practice question. So a prescription reads fluoxetine 0.02 grams orally once daily. The medication label states that each tablet is 10 milligrams. The nurse prepares how many tablets to administer one dose? Jara.
Professor, my answer is 2 tablets because 1.2 grams is equal to 20 milligrams. So we have 10 milligrams. I would say we need 2 tablets.
Okay, all right, that seems to be the consensus here. So yeah, you're converting that 0.2 grams to milligram or 0.02 grams to milligrams. And yeah, and then we're looking at how many tabs is 10 milligrams. So it looks like everybody's got that. Fantastic. And here's the rationale for those of you who want it. All right. And we have our code key. So make sure you're paying attention and that you get this. All right. Just a reminder that this is not to be shared with other learners. They need to get it for themselves. And once I take this slide down, it will not be shown again. So the ASN is 4 Whiskey 8 Whiskey Foxtrot 372, and BSN is Bravo Uniform 8 Alpha X-ray Sierra 2 November. All right, looks like BSN works. Fantastic. All right. Going once, going twice. All right, we have our references for this week's webinar. And then questions. So for those of you who do not have questions, you are welcome to leave at any time. This will conclude our webinar for the week. For those of you who do have questions, stick around and we will stay here to answer them. All right, I'm going to go ahead and take this slide down so I can see hands that go up. There we go. All right. Anna, did you have a question?
Hi, Professor. Yes, I do have a question. For the HESI practice, how many times are you allowed to take it? Like, does it just pick up at the first score?
It just picks up the first score.
Oh, it does. Okay, so it's not full points. It just goes based on what you got, the percentage that you got.
For the practice exam, you can take it once and there is no late policy applied, but taking it gives you full points.
Just taking it. It doesn't matter how many you miss. It's just you get the full points then.
Correct, but I encourage everybody to do their best. Okay.
Okay, thank you.
Uh-huh. All right. Paula.
Yes, I have a question. So I think it's Thursday, I get notification to study for HESI. But when I enjoy the section, there is nothing there. So is that a glitch or something wrong?
Is that from our course?
Yes. Yes.
To study for HESI? I'm not sure. I think the only thing that we have is on the calendar is a reminder for the EL webinar recordings. So if you weren't able to attend the EL webinar for that week on Wednesday, they post the recording. So that might be what you're looking at.
No, it's a head study. Last semester we had it with a Professor Tara, I think her name is, but these keep going and is when I
Okay,
enjoy
I
it,
don't
there's
know. We don't
nothing
have a
there.
HESI in this course, so I'm not sure what you're referring to. So it might be left over from a previous course. Yeah, so it looks like some of your fellow learners have the same thing and it's left over from last semester. There might not be an end date on the calendar invite. Okay. Mindy.
If we retake the HESI over and over, will it keep our best grade?
It will not.
Okay, thank you.
First attempt. Yes. Yeah, and there isn't a HESI, like you said, this is a HESI practice exam. And so yeah, you get one chance to take it. All right. And then Obehi?
Yeah, my question is there any like particular grade that you must have for the HESI practice?
Not for the HESI practice exam, no.
Okay.
But let's see. Yeah, so again, a reminder to make sure that you're using your Nightingale email. You'll get full points for attempting it as long as you use your Nightingale email to take it. But also, again, I encourage everybody to do their best on it because it'll help prepare you for future HESIs. Okay. Jarek.
Thank you, Professor.
So there's two case studies for
Mhm.
this week, the schizophrenia and the Alzheimer's. Are
Correct.
they going to be by completion, like the HESI, or are these graded?
I believe those are graded. Can you help me, Professor Jackson? I think those
Yes.
are graded. The practice exam is
Mhm.
based off of completion. Is that correct?
Yeah. First attempt
Okay.
for the
Okay.
Thank you.
case studies. First attempt
Okay.
grade, yes.
All right, thank you. Yeah, I know we have 3 separate HESI. So, and they don't go to the same place. So make sure that we had this issue in previous semesters. So make sure you're accessing them from the assignment in the module. Otherwise, you won't see all of the assignments. So they have different links that go to them. So make sure that you're doing 3 separate HESI assignments this week. All right, Anna.
Sorry, I was just wondering, do we have to upload like a picture like we have previously done it, or would it automatically after they're graded it goes into our
So you don't have to upload a picture. We will go in and manually grade them after the assignment closes. So, give us till Wednesday of next week to make sure those grades are in, okay?
Okay, and I know that you mentioned that there's 3 of them, but I only see 2 of them.
There are 2 case studies and 1 practice exam. And like I said, you have to go through those individual links in the modules because they are in different places within Elsevier.
Okay, because I see the Alzheimer's, the HESI exam. I think maybe that's what it is. Okay, perfect. Thank you.
Schizophrenia. Schizophrenia is the other one. The schizophrenia case study.
schizophrenia. Okay.
Yes.
Okay, very good. Thank you.
Mm-hmm.
Yes. Right, I think we got them all, huh?
All right. Awesome. Well, have a great rest of your week and reach out if you have any questions. Otherwise, have a good one.
See you next time.